Next up, we have a great friend of mine. Just a little background story about Dr. Dhoon. You guys know that he is a mastermind member. He's also a coach. Very, very successful dental practice. Most of that has come because of his systemization and his implementation. Really, really, really good implementer. Just one of those guys that there's a number of masterminders that you know. They're kind of like, it's kind of like the kid that gets more ground balls after his practice from his dad, and they're constantly working on their craft a little bit more than most people. I'll tell you, there's a number of people that come to mind. Dr. Sean O'Grady is like this. Summer is like this. Matt Slifka is like this. Taher is like this. They have a really, really great team surrounding them. We'll be at mastermind meetings and we'll adjourn after 10 hours of doing hot seats and just an exhausting day, and you'll see these pods of people that want to hit it when it's fresh, and they'll spend another 2.5 hours with their office managers and their integrators working on stuff that they're going to do exactly when they get back to the practice on Monday morning. And that is Taher and his team, Rose and his whole executive team, including Chris Richards, and just, I mean, I know them because they're always there. They're always working extra. They're always reaching out for more resources, and they're just incredible. Add to that type of infrastructure, operational infrastructure, and that desire to be the best, and you add an advanced surgical suite, which happens in phase 3 and beyond. Once all the operational infrastructure is in place, you add to that advanced clinical suite, and you are onto something very, very exotic and very, very promising and very, very profitable. So what Dr. Dhoon has been able to do is he added IV sedation to his practice. He has an incredible second provider at the practice named Dr. Dan Brisky, and together those two are about as advanced surgically as you could possibly imagine. Like on any given day, they're doing an arch or two, sometimes 3. They can knock these full arches out in an hour and a half and actually deliver the provisional in that same period of time. So really, really high-end stuff. $50,000 to $75,000 days are not rare at this particular practice. So it's really crazy. What's cool is that, you know, one day after one of the mastermind events, Taher and I were talking. I'm like, dude, you're sitting on something really, really cool. We could help a lot of people if you could teach people how to do this. So he came out to my practice, and we set aside 6 different patients. And we did 12 arches on my patients with him and Dr. Brisky standing over the shoulders of me and my associates. So that was the initial plan, that they were going to travel around and they were going to stand over shoulder and allow people to use their own patients in their own facilities so that their assistants could learn and the doctors could learn at the same time. It's in a comfortable environment. All good, not scalable. I'll tell you, from somebody that used to travel to practices 3, 4, 5 times a week, it's not scalable, it's not good for a family life, and it's just not a viable business because once you stop traveling, the income stops coming in. So he created Colorado Surgical Institute out of his office in Greeley, which is not that big of a practice. The cool thing about Colorado and Arizona is you can apply for a temporary license as a clinician, and the state will grant that to you. And for 10 days, you can put your hands on Colorado patients, even if you don't have a Colorado license. We can do the same thing in Arizona as well. So those are the states that are perfect for these types of surgical and hands-on institutes. So we created Colorado Surgical Institute out of his practice in Greeley, Colorado, and that is exactly what we do. They have incredible screening processes. So these are actually Dr. Dhoon's patients that for whatever reason couldn't afford to have an advanced clinical procedure. And then they get referred to the institute and they say, hey, I'll do this $50,000 worth of arches for you at a decreased price, basically the price of the lab fee and the materials, if you will allow yourself to be a teaching case. It's going to take a little bit longer. You're going to be, students are going to be working on you. They're licensed doctors, but they aren't proficient in this yet. But Dr. Dhoon and Dr. Brisky and all of the surgical mentors, myself being one of them, will be standing over the shoulders of all the attendees and able to place these implants, do these lateral sinus lifts, do these crazy advanced procedures, transporting mental nerves and all this crazy stuff. So that is where it was born. It is a year old now. We've sold out every single course. And Dr. Dhoon is going to talk a little bit about his journey, a little bit about Colorado Surgical, and a little bit about how advanced surgical procedures and advanced procedures in general, an exotic suite of clinical care can really, really accelerate the growth of your operation. But first, keep in mind, guys, remember I'm folding this into the business side of things. Do not put the cart before the horse. Your answer to lack of cash flow and not enough money in the bank at the end of the month is not advanced surgical procedures until first you put the operational infrastructure in place. Okay, so I mean, I don't want to beat a dead horse, but that is so important that you do these things in order. No IV sedation, no Colorado Surgical unless you have a plan to learn how to integrate these into your practice in a profitable way first, okay? All right, so without further ado, I want to introduce my great friend, Dr. Taher Dhoon.
All right, how's everyone doing tonight? We are, well, not tonight yet, but we'll be getting some drinks at the bar, and I think it's at the White Party on Mark. So today we're gonna be talking about all-on-X procedures, and more so than not, I wanna share with you kind of the evolution of how this business was formed and how it came to inception. It's interesting being on the stage here today because usually, I'm up talking about osteoinductive, osteoconductive, osteoblast and osteoclast and things like that at more clinical conferences. But the inception of this whole company happened here. 2018, I was actually in a pretty rough spot and I was dead broke. And I had been a dentist for 3 years and my wife was a dentist for 3 years. And, you can probably hear in my voice like the PTSD I have from that moment where my startup went south, where my legal representation wasn't good, where the demographics and the representation from the brokers wasn't adequate. And I had to go to my wife and say, hey, I think we lost everything. Because at the time I was just unsure of what had happened. It was like being on a Spike Lee movie where they're floating on the escalator, not quite knowing if this was reality or not, because you anticipate your career taking a certain trajectory and having it be very successful. And to be hit with the realization that you've actually made a very critical error, but to have that impact your family. Like we had put a down payment on our house and she was pregnant with our first kid. And I had already scorched the earth at my associateship at the corporate office where, I kind of did the movie Waiting, where it's like, F you, you're cool, F you. And so I didn't have a job to go back to. So, and I was with another consultant. And that's why earlier on the stage with Mark, he was like, this guy was skeptical because I had gone through a whole nother consultant, trusted in their advice, and made a very critical error where, I lost $65,000 with nothing to show for it and 2 years of my life. So I called all the brokers, told them I will drive anywhere, find me a practice. And so I live in Denver, had to drive all the way up to Greeley, which is about an hour north. And, I found a value add practice. And that's why me and Chris Green have the book, The Practice Launchpad, because we help docs with startups and acquisitions and we help them, not make the mistakes that I made and help them guide them through that process. And so it's interesting being here after joining DSI in 2018 and taking, the $1.1 million practice with a 68% overhead to a $7 million practice with a 45% overhead. And I hopefully say that with some humility where, this is possible with the clinical suite, with the efficiencies, with the right team, with the right guidance. This is possible in your practices. And then to give you guys clarity on how we're actually doing this, it's 5 doctor days. I work 2 days a week. Dr. Brisky works 3 days a week, and we have 3 hygienists and 6 operatories. So it's possible in your mid-level, smaller level practices to do this stuff at a very high level with a good quality team. the most important thing, I think, and I think at the end of the day, and sometimes I'm ashamed to say this and sometimes I'm not, but I got into this stuff for the money. My brother's a anesthesiologist and my parents are Indian parents, and they were like, hey, go be a doctor or go be a lawyer or engineer, like most Indian parents are. And so initially I wanted to be a teacher, and I got into it for the wrong reason. But through the journey, through this evolution of creating this type of practice and the connection you can have with the patients, you find true meaning. And so I want to introduce Chris Richards. He is the director of all the businesses that we have, including Colorado Surgical Institute. Before he came on board, we were doing 1 to 2 arches a month. Now we're doing about 16 arches a month. All I do is full arch, sleep apnea, and orthodontics. So Chris is going to talk a little bit about what I believe is the most important part of this, and then of course we will dive into the surgery.
Yeah. Hi, everybody. This is my second summit and probably second of all the different events. I've been to a couple of mastermind events, and they are some of my favorites. I've been to a lot of other events, a lot of other industries, but I think kind of leading or moving forward from what Dr. Dhoon had mentioned, one of the things that I've really come to appreciate about coming to an event like this is we have doctors and clinicians and administrative staff, people on the business side, who come from all across the country. Everyone has a very diverse background, but you're all here under one umbrella, and that's to connect with other people. Dr. Dhoon and I were outside just about an hour ago, and we were able to connect with a couple of other dentists outside who had very similar problems to us. And we were thinking that this is a very unique problem to what we were doing. But that's so awesome about a group like this. And within our own practice, we started to realize as we were integrating and really developing our own implant program that the additional revenue that comes from these high producing procedures or high production procedures is amazing. The things that we've been able to do for our team because we have additional resources, the growth that we've been able to experience because we have additional money and stuff coming through has been so cool. But as we got a little bit deeper into our program, we started to realize that we could do just about anything to make a lot of money. And all of you could have done a lot of different things to make a lot of money without the $700,000 worth of school loans that it takes. I mean, realtors make a lot of money, politicians make a lot of money when they know the right people, but the whole reason that you guys are here and kind of the why we got into these procedures is because when you start talking about these high dollar procedures, these transformational surgeries, your ability to make connections with other human beings, with other people on such unique, life-changing levels really is such a beautiful thing. And one thing that I would like to, spend my next 3 minutes talking about is it doesn't matter if you guys are able to drop 16, 17 arches, but if your why doesn't exist, then it really doesn't mean anything. As human beings, I have a psychology background, so it's, that's kind of the perspective that I take a lot of my thought processes from. We are very uniquely designed to find connections throughout our lives. We start this connection kind of process as little babies. We've got families, parents. We look for other people that are similar to us, and we gravitate towards them. The importance for making a connection for a lot of people can be life-changing. A couple of years ago, I started to realize that within my own life, I lacked certain connections with myself, connections with people around me. Before 2018, I had what I felt was a pretty awesome life. I was married and had kids and jobs that were kind of going places, but I still felt a lack. I felt a deficit in being able to connect to myself authentically and to other people authentically. And That's when I realized that at the age of 35, I needed to accept who I was, and I came out. And so now it has been 4 years, and so I guess in the spirit of Pride Month, I'll come out to all of you guys, all of my new best friends. It is challenging when you seek to make these connections with other people, when you seek to make connections with yourself. It's terrifying. Say, very, very similar to when you are looking to integrate some of these transformational surgeries into your own practice. It's really scary to go and drop $100,000 on scanning equipment, or a couple of $20,000 on surgical courses. But the moment that you make a decision to actively connect with other people is the moment that your life is going to change. We, of course, as you're looking at some of these pictures up here with some of these patients, the changes in their face is amazing. And so as we look at our patients, we can know that their life is going to be forever changed. But the one thing that we started to realize is that surgeries like this that are truly transformational, it doesn't just change this one person. We have a patient, John, and Dr. Dhoon will go over his video in just a minute. He was 25, completely edentulous since his 20s, since his early 20s. He's got a small son named Liam. What we started realizing is that because John had this transformational surgery, he started talking to more people. He started to present himself a lot more confidently, and he was able to leave his job as a garage door repairman, and he started to move up. So his capacity for earning in his own life completely changed. And what that really means is that now his son Liam has the opportunity to change his trajectory. And not only just Liam, but the generation that comes after and after that. So as practitioners and other clinical staff, we are stewards for change. But not just change in one person's life, we are stewards for people's lives and their changes throughout generations. So as this presentation advances, and as your careers advance, and as you start to integrate more of these transformational surgeries, I implore you to continue to remember that you're not doing this surgery to change a P&L. You're doing this surgery to change the lives of small children that you will never know, or influence somebody for the better in ways you can never imagine. So I'm going to be out here the rest of the day, and I am really excited to connect with you, to connect with your staff, and really help you develop the why for your own implant programs, or the why for your overall transformational surgeries. Thank you.
So I definitely encourage you guys to talk to Chris. He is absolutely a wealth of knowledge when it comes to psychology, how to market these things, how to build this program in your guys' practices. Now, the connection aspect for me is these are my 3 monkeys, and they keep me busy, 5, 3, and 1. And so at the end of the day, he touched on John and his kid. But also on the absolute other end of this is before our February course, I get the call from my parents. My grandmother passes away, and she was really near and dear to me. She helped raise me, and she was present for me. And at the end of life, she was in India, emaciated face, 1 or 2 teeth left. And I find it super difficult to remember what she looked like without looking at a picture of her. And so I wish that someone would have done this procedure for her so my mom could have buried her, looking the way she should have looked. And that is the responsibility we have, is we need to get these patients when they're healthy enough to tolerate the procedures, not just because it's teeth, not just because it's nutrition from the physician. It's confidence. It's the daughter to bury her mother, the grandson to have that memory versus looking at a picture. And so the really cool thing about dentistry is that we didn't used to be able to do this. You can't, do these cases all the time because of oral surgeons and periodontists. Well, with the technological curve on this stuff, it's actually easier than ever. And so I'll show you John's story and then I'll hop into the surgery.
Both upper and lower full arches and implants. A whole fallout with losing all of my teeth started when I was in high school. I didn't have proper care at home. Once I got out of high school, I really didn't have the ability to do it myself because I didn't make a whole lot of money. Kind of the breaking point for me when I couldn't take it anymore was when the pain wouldn't stop. I was doing emergency dentist visits probably every other week, and that was way too expensive, so I just had somebody remove them. And then my fiance got me a visit at this dentist office, and that was where I found the people that were willing to help me. I'm a lot happier now because I can smile like that. And I get a lot of compliments at work from my colleagues because I look better. When I first started losing my teeth and I could see all the holes and the damage and everything else, the infections, I felt like I needed to hide from the world. And when I finally got all my teeth actually removed, I was kind of thankful for the pandemic in a way, because I hid my face with a mask. So, and now I can smile. I feel 1,000 times better, like I said before. And I like to look at myself in the mirror again. Dr. Rebecca Steinbeck did the majority of the work. Thank you. I also want to say thank you to Dr. Luda. She was awesome. I want to say thank you to Dr. Mark Costas for the work that he did with me and getting me to the position I am right now.
And so these are the surgeries that we get to do every single day, but these are the surgeries and the patients who are in the queue for the Colorado Surgical Institute as well. We are going to touch on the profitability of these procedures. I want you guys to leave with the tactical aspect of it. We will come back and touch on this connection piece because this is the motivating force. This is what I found halfway into the journey. Unfortunately, not finding it from day one, but I think that these conferences are really cool because we get to do these amazing things for these patients and have impact into people's lives. And at the same time, you get paid for the service that you're providing, and you're not providing teeth. And when your team understands that this is not just teeth, that's when you can justify the $50,000 to do this procedure. So Mark has already covered all of this. I'm going to skip over some of these calculations on phases and black belts and things of that nature. I think we all know how to calculate supplies and material costs. Everyone will get the PowerPoint if you guys need it afterwards. We obviously get into the analytics. I'm super left-brained heavy, and so we calculate the cost per procedure. We calculate everything from A to Z, so we know exactly how much everything costs as we go through everything. From a production cost perspective, you have your fixed and variable costs. We also calculate support staff, facility costs, because all of that does add up over time. And then we're going to hop into the actual profitability of this procedure and how the advent of technology and lack of lab techs needed within the practice and lack of chair time can actually make this worth it. Because when I talk to other doctors who are doing this procedure and we're coaching them through DSI, they're sometimes telling me this is not profitable after all of the pickups and all of the time in the chair and all of the broken prosthetics. And so we'll kind of hop into all of this. So from an implant perspective, You can use any implant you want to use. I've used Nobel, Blue Sky Bio, Zimmer, BioHorizons. Now I use Neodent, and by far the best full arch implant, and I've switched my entire practice over to Neodent since, but by far the best implant. No bone profiling, the inventory is less. When you get into the full arch game and you have a spinner, you send it back in, they'll give you your money back. You got to do a little paperwork for it. The MUAs, or the multi-unit abutments, those you can't return, so kind of pick it out accordingly and make sure that you choose the right one, because it's $125 every time you open one. Bone graft material, we do a lot of reduction with double action rongeurs to harvest the autogenous bone. So that's the osteoinductive component of it all. We're going to use that, and then the amount of bone growth we can get over certain places is actually pretty phenomenal. From a design perspective, and I've overestimated a lot of these numbers, but from a design perspective, you can pay designers, anywhere from $280 to $500. I used to give out my designer's information, and then he got completely swamped and inundated with stuff. So reach out to me personally, and we'll give you some of the designers, because sometimes they have egos, other times they run late. They sometimes forget that there's a patient attached to the procedure, and then you have people waiting for a very long time. But resin fees, if you own your own 3D printer, Voxel is the team that set everything up for me, and they're here as well. I definitely would say get a 3D printer and an intraoral scanner to start. You don't have to buy the $60,000 mills and the $40,000 iMetrics right off the bat. And then for zirconias, if you own your own mill, we've overestimated at $800. At the end of the day, I factored in payroll cost, MEO, stain and glaze, all the other things. Maybe you have to remake one. But really, at the end of the day, these pucks are like $165, and it's not even factoring in the amount of crowns you can get out of it after one arch is done. So again, a drastic overestimation. And then for zirconia from a lab, $3,500. So we've estimated it coming out to 14 hours for an assistant. I'm heavily assistant driven. All I do now, and again, I had to spend a lot of time training people in the beginning, but all I do now is I walk into the room, I place implants, I graft, and I leave. I don't place multi-units, I don't place scan bodies, I don't do iMetric scans, I don't do anything. I don't even print the arches, I don't design the arches, I don't do the annexed and gums on the arches, I don't adjust the occlusion. I literally will go in, after the occlusion is adjusted, I'll go check it. My team is just as good as I am, unless there's like some condylar issues, and I just go take all the credit. So I just go in, drop the implants, get a cup of coffee, move on to the next thing. But here's the thing, through repetition, we got efficient. And that's what we teach. We teach how to do it efficiently and proficiently, because at the end of the day, if you're spending 5 hours doing your arch, like my first arch, it might not be profitable. But now we're doing edentulous arches in an hour. We're doing people who have teeth present. We have to edentulate and ridge reduce and all of that in about an hour and a half. Well, I mean, it's a super profitable procedure at that point. So disposables, total expense if you own your own lab, total expenses if you are delegating it out. And then if you're the owner and you have associates running this at a 30% of production on a $25,000 case, here are some of the numbers. Here's some lab equipment. If we want to hop in and talk about labs, we'll talk about that separately. But if you contact Zubler, they have a really great product. They're coming out within an 11-minute zirconia sinter cycle that's in beta testing right now. And their product is really phenomenal. And these guys are actually like physicists and guys who know like actual science who are developing these things versus other companies that just throw this thing in without like much R&D. Sprint Ray is good, but the Einstein printer, I think if I were to go redo this, I'd go and get the Einstein printer. So all in all, we kind of calculated it out where if you bought your own lab, 36 arches later, the thing is paid for. However, we did not factor in all the single units, all the crown and bridge, all the clear aligners, all the wax ups, all the things you can do with it at the same time. And then if you went with the Roland or the X-Mill, I have the X-Mill, it's about 42 arches. So profitability per arch. So if you're charging $25,000, you own your own lab, you're doing this in an hour and a half, I mean, you can clear $21,000 in profit on an hour and a half of work. And so that's how we can do 5 doctor days, projected to do 7 million, and keep the overhead low, is because we've gone through the ringer. I've burned hundreds of thousands of dollars on the wrong equipment. I have a mill that just sits there that I don't use. I have 2 3D printers that just sit there that I don't use because we beta test this stuff for you guys and we tell you like what actually works. And I think one of the unique things about our program is I'm a general dentist, right? So I have a general practice. We treat everyone from 6 months old all the way to 106 months old. And so I'm in the trenches, I'm doing this with you guys, and then I figured out a way how to incorporate this within the practice. If you do not own your own lab, then it's about $17,000 in profit, which is still really great if you have the efficiencies down. And then obviously more estimated math on marketing, paying your lab tech, etc. The consultation process is the linchpin. And that's why Chris, when he came on board, changed the trajectory of our entire practice and what we could do. It's because you have to be able to have long conversations with people. I mean, these people are coming in and saying, my wife has been in pain for 10 years, off and on, and she's a shell of her former self, and she's miserable sometimes, and then she's good other days. And imagine the impact on someone to see someone who they care about always in pain and not showing up as the best version of themselves. Or the grandparents where, children, like I have 3 kids, and they will point out everything, They point out daddy's, dome every once in a while and ask me why I don't have hair. And it's like, because it went a long time ago, man. So it's like, at the end of the day, the kids will point out to the grandparents, why is grandpa missing a tooth? Why is grandpa ashamed to smile with us? And so they come in and you can't have a 10-minute conversation with them. You need to have the hour-long conversation. Well, your guys' productivity per hour is huge, and you cannot be sitting in there having that hour conversation. You need the right team in place to come in, handle a half-an-hour phone call, schedule the hour consultation, protect your schedule at all costs. Because when you do free implant consultations, the no-show rate on free consultations is very high. And so what we do now is we schedule half-an-hour blocks for the free consultations, and if they show up, they get a CBCT. If there's room in the schedule, they talk to the treatment coordinator, who is Rose or Monica or Chris, no longer Chris really, and Rose and Monica are here too. So, I mean, if you guys want to pick their brains, they are way smarter at this whole process than I am, but they talk to the treatment coordinator. If we don't have time, they just get reappointed. Now we know that they've shown some interest in it. We also give them the option to set up a virtual consult, because through some of our marketing and our TV commercials, we're having patients coming in from Nebraska, driving 5 hours from Aspen, Denver, Wyoming. And so we'll talk about Randy Alvarez and the Wellness Hour. Anyone who's doing a lot of full arches has done a commercial with Randy, and then he airs it everywhere. It is a huge investment, so make sure you're like really in it to do this, because once you get the commercials going, I have people who have seen these commercials and say, hey, I feel like I've known you for 2 years watching your commercial, and they come in and they feel like there's rapport already built. So you have to have the systems in place to guard the schedule, to do the consultations, but to dial in and be present. And I would like to think, and it's not only due to this procedure, but I'm more present with my wife. I'm more present with my kids, because when I have this conversation with the patient, I have to remind myself is like what they're telling me, they're being super vulnerable, and they're telling me some of the deepest, darkest, most embarrassing things about their everyday lives, and you have to dial in and be present for that. And so when you remind yourself when you go home, like, hey, I'm gonna be present for this conversation. I'm gonna put my phone away and watch my kid do this weird Taekwondo move that's not Taekwondo and be like, that was awesome. You just have to, it teaches you how to be present. So again, we go over all the options. We go over medical history. I'll cover a few things with you. Oral bisphosphonates used to have a super bad rap. When you get more proficient, you have more reps, don't worry about oral bisphosphonates. Of course, go at your own risk level. There is an increased risk of failure. Managing the failures on that could be problematic. IV bisphosphonates, some people are saying take a 6-month hiatus on it and then do it. I still refer, the reclassed and Proleas and things like that out. Head and neck radiation, look at the Grays units, talk to the oncologist. SSRIs, so through COVID, we saw an uptick in antidepressant use, SSRIs can really cause some catastrophic failures. And so make sure with the SSRIs, you're having conversations with them. Do not take the patient off their antidepressants. It will throw them into a tailspin. Talk to their physicians. Make sure you never change another doctor's medications. And then obviously oral tobacco products and all the other stuff we know. So Proceed Finance, I mean, they actually have the whole crew here for you guys to get this set up in your practices. But John from Proceed, amazing human being. He will buy all of you guys a beer tonight if you go talk to him. So definitely go pick his brain. But this is how you get people financed for these things. A lot of people aren't going to come up and say, hey, I have $50,000. They need to figure out a way to break this up over 8 or 9 years. So Marcia's from the course. Actually, that's Dr. Agatep over there. And she came out and literally changed the trajectory of Marcia's life.
Oh my God. Oh my God. Oh my God. You're so pretty.
You look so different.
My face is so numb, but Mom loves it so much. I can't believe this is me.
So who thought she was too protrusive, right? I did, way out to the parking lot. So what you do, and that's, I mean, here's the thing. When they come from like a terminal dentition and you do that, they're like amazed and happy. Don't point out your imperfections and your temporaries right away. I would go in and be like, oh yeah, the lateral looks a little off. And they'd be like, oh, I thought this was great, thanks. So make sure all you have to do, take cosmetic pictures, upper lower bite scan, send it to the designer. They're gonna intrude it and move things around, and then you can print it out in like, an hour and a half, and then swap out the prosthetic. But don't point out the imperfections and everything, because we're all neurotic dentists. You wanna go in and make it perfect. It was a very special moment for the patient, and then you take it away from them. So it's just, I speak from experience, obviously. Okay, so we're gonna review how to do the surgery in itself. So at the end of the day, you can flap first, or you can extract first. Dr. Brisky, who is probably one of the best surgeons that I've ever seen, super efficient, faster than I am, rocket ship strapped to his back. His surgeries are all freehand and they look like amazing, like they're from textbooks. So he is also one of the clinical faculty, or he's actually one of the founders of Colorado Surgical Institute. He is a wealth of knowledge, and he will quote literature at you if you have a question. So he extracts teeth and then flaps, I flap, and then I extract teeth because I like to squeeze the alveolus while I extract the tooth so that I'm not fracturing the buccal plate. We use a bowling pencil, wipe it with Cavi, and we'll mark our ridge reduction. You can look at your CBCT and measure the amount of reduction you need, look at the cosmetic pictures, and figure out exactly how much you need to reduce or what prosthetic design that you need. You can do FP1, FP2, FP3. The FP1 design is very difficult to do if you're doing it in like the pure sense of like what an FP1 is. So I would say stick with FP2s and FP3s for now. At the end of the day, you just communicate that with your designer, but it has to do with where prosthetically the lip is gonna be. We also maybe recommend looking into some Botox and fillers, because if you can turn the masseteric and temporalis muscles out or off, or at least decrease the contraction force, you're not gonna be breaking as many prosthetics. And then also sometimes it can help with like TMJ issues and having them locked in and figuring out where the condyle is and getting things to loosen up a little bit. But we mark our reduction with the bowling pencil. We'll take the double action rongeurs, which have 2 hinges in it, Sometimes you can use a single action rongeur and do the reduction. However, when you get to that lingual cortical bone, palatal bone, sometimes you don't have enough force to get it off, but this is when we're harvesting it. So we get a not a dapping dish, but one of those sterile saline cups. Saline goes inside, and then we do the reduction. The assistant is scooping the bone out of the double action rongeur, and then we have a bone grinder on the side. Second assistant is grinding up the bone, getting it preserved. We use gentamicin inside the graft. Really, at the end of the day, it's whatever you want to hydrate the graft, but just make sure it stays hydrated and doesn't dry out. We're using a $20 Mossad ruler. And so I talk about these things because I want to show you the most cost-effective way to do it. You can absolutely plan this out, do it guided. I am not knocking guided surgery at all. However, in my experience, anecdotally speaking, we have about a 20% not fit rate on the guides. So I encourage people to, if you want to go guided, use a pilot guide only and then do tactile sensation with the rest of the drills. We under prep the vast majority of the osteotomies unless we're in D1 bone. If that stuff is like concrete, then obviously drill to your appropriate depth. But the Mossad ruler has measurements on it, which also then in a surgical setting will reconfirm the amount of reduction that you're doing. You'll let the lip drape over. On the upper, we want to see a minimum of 13. Sometimes 12 is adequate. Once you get to 15, you're good to hide that transition line when the patient is speaking. At repose, you don't want them showing too much tooth structure unless they're a little bit younger. On the bottom, we go about to 1825. And if you come to the course, you get a 600-page curriculum, so I'm not going to be covering all 600 pages today, but just a few of the cliff notes and bird's eye view type of topics. So what I used to do is I would take the land spur, I put it inside the extraction site. What now I'm finding I'm doing more often is in between both extraction sites, I'm going in between in this little triangle of bone. We have more native bone in contact with the implant, and we're going a little bit palatal. With the palatal bone, it's so cortical, you have to be very intentional about not letting the implant on insertion drift buccally. A lot of people can fenestrate out through the buccal because on thinner ridges, the palatal bone and the lingual bone is very cortical, and sometimes in that submandibular fossa, you have these angles that will either redirect your implants or your implant will bottom out. Sometimes people would think drilling into the sinus or drilling into the nose is scary. But the thing you actually want to do is take that land spur and pop into the nose. Don't drop the whole thing in there, but pop right through it a little bit. Pop into the sinus. It's called bicortical stabilization, where if your implant is threading into the bone and you bottom out on the antral floor or you bottom out on the floor of the nose, the implant's going to stop. You're going to try to rotate it further, and all the threads are going to break loose, and you're going to lose stability. So make sure you pop through it, and that way, if the implant needs to drive in further, you're actually going to let the apex go through the base of the nose or into the sinus. These are the direction indicator pins. I really recommend everyone use them. It tells you what type of multi-unit to use so you don't open up things and waste inventory, because obviously we're teaching the profitability of this procedure as well. And we don't want you to lose $125 just by picking the wrong multi-unit. Multi-units are placed. We torque them to 20. If your implant stability is under 20, don't torque it to 20. You'll rotate your implant. If you get, max out the torque values on your implants, go ahead and put it up to 25. You don't traditionally need to go above that with the Neodent system. If it's another system, talk to your rep about where they want it. Some people are at the 30 marker and the Nobels. These are the refs. So these are used for soft tissue location when you're sending the information to the designer. So we put these on, we'll bone graft around it. We'll use a lot of PRP and PRF over the top. Depending on the defects, you can use different types of membranes, and then you'll suture over the top. Typically, you don't need to do a huge periosteal release on any of these cases, because when you do your ridge reduction, you'll have adequate tissue to close. Unless you're doing block grafting or anything else, you don't have to do the periosteal release. You want as much keratinized tissue on the buccal of everything, so do not trim away your buccal tissue unless you got 1.5 miles of it. On the lingual, you want to be very intentional about keeping that keratinized tissue on the buccal. If you can see in the picture, In the roof of the mouth, we are putting a TAD in the roof of the mouth. It's basically a Phillips screw, and we put 3 of them in there. The reason why we do that is on your pre-design, before you start the surgery, the screw goes in the roof of the mouth. Post-surgically, the screws are still in the roof of the mouth. So when the designer is merging things together, they have a point of consistency to merge the images together so your occlusion doesn't get canted or things don't get rotated and you get the Tom Cruise look. Obviously, don't forget to remove the TADs at the end. On the lowers, if the second molars are present, you can use your second molars as your quote-unquote TADs. If second molars are not present, you put the TAD in around the second molar. Your flap design needs to be mesial of the TAD, so the TAD can remain stationary the whole time. Bone grafting goes in, PRP over the top. We do a little poncho technique where we stretch it over the top. Texas 2-step suture, start in the front of the mouth. Keep it running all the way back to the front of the mouth. It goes horizontal matrices on the way down, goes continuous on the way up, tie it off in the front, and then run the exact same thing on the other side. Multi-unit choice, ICAM, iMetric. These things were back ordered. I think you can get it in like July and August. But at the end of the day, the chips are coming out, the dice on the side. Again, my team is doing all of this. I've never done a scan, I've never done a Medit scan, never done an iMetric scan, but I have given my team the resources they need to do this, operate it, have the equipment they need so they can do this effectively. These are the TADs in the palate. I do a triangle configuration now versus a straight down the suture. Zirconia, direct to multi-unit, no more pickups. These things screw right down. We're using desk screws. The code is, I think, 19.018 or 19.406. They tie down and screw down a little bit better than the others. These are the patients who wear masks all the time. Someone thought that picture was photoshopped, but she saved up for X amount of years, works at Walmart, and these are just her temporaries. So Shauna's surgical presentation, I'm kind of flying through this real quick. This is another case done at the course. John's case, before and afters. He had block grafting done at 7 and 10. And these are the pictures they send us. We don't even prompt them to send us these things. Jackie, another patient from the course. Dr. Brisky does all the pre-surgical setups and designs. I always try to over-engineer a case. We don't usually place 4 implants, we'll place 6 implants. We will usually max out the stability on these things. But this is Jackie, sending us a picture of her with her son and granddaughter and feeling confident to have Thanksgiving with them again. So this is the rewarding part of what we can provide people. I love Temo, by the way. He broke my back hugging me.
De Mioki, Chihuahua. Mi razón de que me arreglé mis dientes es porque mis dientes estaban muy feos desde que yo estaba en Mioki, Chihuahua. Tenía vergüenza reírme, como mi esposa me decía que yo no me reía por lo mismo porque tenía mis dientes feos, y en el trabajo me daba vergüenza, o con mis amigos o con mi esposa propia, que me daba vergüenza. Y ya tenía a mi esposa rato diciéndome que me los arreglara, y pues cuestiones a veces del dinero. Tenía mi crédito, pero lo tenía estancado. Hicimos el crédito aquí para arreglar mis dientes y lo pasamos, gracias a Dios, y con el doctor. Y él me miró y dijo que si había posibilidades de arreglarlos, y gracias a Dios aquí estoy. Mírenme diferente. Es emocional, pero no para un segundo. El río más, pasa la vida, y gracias a mi esposa que me apoyó también, y gracias al doctor y a la persona que está grabando, que es unas grandes personas, y estoy muy contento con el trabajo que hicieron. Y miren mi diente diferente. Ya puedo platicar mejor con mis amigos, con mi familia, no me da vergüenza, pero I'm happy, man. Gracias.
So once you get these patients who are dying to leave you these testimonials, and you put this on social media, and you put the ad spend forward, then at that point your marketing budget goes down significantly. And these patients are telling all their friends and family. Temo has sent a bunch of people to us. These patients have friends who are like them, who struggle with the same things. Just like I have a bunch of dentist buddies, they have a lot of friends who are in a similar situation. I have a lot to talk about in terms of surgery. I want to be respectful of the time. We are at the booth at Colorado Surgical. We do have a course that covers just socket preservation, how to do this efficiently, how to use the cytoplast and suture over the top. There's just so many things that you can do where you don't have to start off with full arches, but you can start off with socket preservation and wisdom teeth and single implants and getting proficient at these things first. This is how you build a profitable practice, is by doing the quote unquote surgical bread and butter stuff and then getting into full arches. You do not have to get there right away. It took me 10 years to get where I am. Everyone in this room is in this room for a reason. A lot of you guys are students, and I think that's awesome because you're starting off doing the right things before you even get the diploma, and then you guys can do it in 3 years. So thank you so much for your time and attention. I really do appreciate it, and I hope to have a conversation with several of you at the bar.